Good afternoon, dear colleagues. Today I want to talk about the preoperative therapy of heart failure in infants with congenital heart disease. We are currently observe a trend to higher mortality in congenital heart disease in Germany up to 2014 without to know the reasons. This survey of the European Society of Cardiology show that Germany is the country with the highest heart surgery for congenital heart disease in Europe and the highest number of interventional cardiology in children with congenital heart disease. However, other countries in Germany, like Sweden, observe a peak in the survival of children with congenital heart disease starting in 2000. Earlier, there is a clear benefit of patients who are receive an intervention, a surgery or interventional cardiology, showing the blue line, and those who don't receive an intervention in the red line. Today, the results show a higher mortality in patients who receive an intervention compared to those who receive no intervention. Comparing the mortality in different health systems, there are every time the same picture. Most patients who die from congenital heart defects die in infancy. This is the same numbers in Germany, in US, Chinese, and in a European survey. Uh, Around about every second child who die from congenital heart defects is an infant. There are different treatments of heart failure in infancy, showing in this slide, with most countries use diuretics, most countries use ACE inhibitors, and only a few countries use beta blockers in the treatment of heart failure in infants with congenital heart disease. In US, there's a trend to use digoxin in infants with hypoplastic left heart syndrome. Today we know the numbers of affected children worldwide who had congenital heart disease. There are more than 3 million children who suffer from congenital heart defects. Around 200,000 die from this disease, and half of them die in infancy. 2/3 of infants who die from heart failure. That are around about 80,000 infants who die from heart failure worldwide. However, there are only a few studies who prospective analyze the heart failure treatment. In infancy, there are only 3 studies who have a prospective randomized design that is our CHF Pro Infant study and the VSD PHF study from India. Both use propranolol. There is the US enalapril trial from 2010, and there is a prospective analysis of the Gießen approach using bisoprolol. No other studies are published to the therapy of infants with congenital heart disease. There are bigger studies in children who are older, although there are not so much children who are affected. The US carvedilol trial used carvedilol in patients older than 1 year, and today there is a panorama heart failure study using sacubitril/valsartan. Despite the very good results of our CHF Pro Infant studies, I was not supported from the German or international societies to further develop this therapy. My own personal beta blocker project are 43 infants who are treated within the last 24 years. The first infants are treated in Göttingen at the University Hospital, and then I use the therapy in a small hospital in the rural part of Germany in Bad Mergentheim from 2005 to 2020. 50% of the infants have chromosome anomalies, and all these infants have severe heart failure with a ROS score higher than 7. 4 infants died despite propranolol therapy. All these infants have Down syndrome and univentricular hearts. All other infants survived with good results. And these are the important parameters of the therapy success in diuretics, ACE inhibitor, enalapril, and beta blocker propranolol. The ROS score improve most after the beta blocker propranolol and not after enalapril treatment in the US enalapril trial. There is a steep increase of neurohumoral activity after diuretics and enalapril and a decrease of these neurohumoral parameters after propranolol therapy. These results are significant. Most of all, we use 25 years ago heart rate variability analysis to prove the effect of therapy on the autonomic nervous system and found a highly significant increase of heart rate variability in a prospective study with higher vagus activities measured by RMSSD and high frequency power. Today, we know that these parameters are very important to predict the outcome in congenital heart surgery. In this abstract from US, there is a significant further outcome in those children who have low RMSSD and SDNN values. This study from Switzerland shows that not only the time in ICU units is higher in children with lower vagus activities measured by HF power, moreover, there is a better neurocognitive outcome in children with normal high frequency powers in orange compared to a control group in blue. We now have to realize that the vagus activity correlate with the severity of heart failure and the neurocognitive outcome. Looking on the data in our infants who are treated with propranolol, there are very low vagus activities measured by RMSSD or high frequency power before starting propranolol. After starting propranolol, there's a significant increase of both parameters, most in normal range. The 2 patients with low vagus activities before and after propranolol therapy, indicated by the red points, died in infancy. Today, we are aware that high frequency power seems to be a very good parameter to predict prognosis in critical ill infants. Compared to normal values in term neonates, our patients have very low power values before therapy. Most are in normal range after the treatment. Preterm infants have very low uh, high power values. Also, very preterm infants below 32 weeks of gestational age. A further life-threatening disease, the necrotizing colitis, show very low high-frequency powers compared to those neonates who have no necrotizing enterocolitis. There seems to be a cut point around 20 milliseconds that predict high mortality in neonates. This slide demonstrates the heart rate variability, BNP, and troponin T values in an infant with severe heart failure due to truncus arteriosus communis and a genetic anomaly. We start the therapy at 10th day of life with very low heart rate variability and nearly no vagus activity indicated as a green color. During this therapy, the heart rate variability increase, the heart rate decrease, and the high anti-proBNP values decrease at the target dose of 2 mg per kilogram propranolol together with diuretics and low-dose hydrochlorothiazide. Only to this therapy we have the opportunity to reach the weight of 3.5 kilogram demanded by the surgeon for corrective surgery. After surgery in a university hospital, the baby come in a small hospital for further treatment with again severe heart failure despite a good operative result, and we change again from sildenafil to propranolol and low-dose diuretics, and again there's a steep increase of heart rate variability at the 75th day of life, and the baby can go home without a nasogastric tube. After hospital admission, the heart rate variabilities remain in a normal range, and the baby grow very good with normal nutrition, without any medication, and without any elevation of brain natriuretic peptide. We are happy that some university hospitals currently treat infants with heart failure with a beta blocker, most of all metoprolol, but there seems an advantage to use propranolol, showing in this two infants. The first infant is the infant with a truncus arteriosus communis that was treated up to the 10 day of life with metoprolol, and we changed to propranolol, and we see the increase of heart rate variability after this change. Also, a further infant with pulmonary atresia and the RVPR conduit that was changed from metoprolol to propranolol, and we see a decrease of heart rate and an increase of heart rate variability with a clinical improvement. There's another infant with severe heart failure due to a ventricular septal defect. The colleagues decided to use dobutamine, of course, severe tachypnea. The baby was ventilated, and we changed from dobutamine to carvedilol, and the heart rate variability steep increase, the anti-BNP values that are very high decrease, the NT-proBNP decrease, and the heart rate decrease, the baby have nearly no heart failure after this change and was had cardiac surgery at an age of 6 months. This case is an infant with Down syndrome who need aortopulmonary shunt, of course, hypoxia and tetralogy of Fallot. After surgery, the baby had very low heart rate variability and severe heart failure, and we start propranolol that results in a further increase of the NT-proBNP value due to pulmonary overcirculation. This is the effect of propranolol of the right ventricular outflow tract. We treat with additional digoxin, and the baby improve, the heart rate variability increase, the pulmonary artery pressure decrease, and there's a perfect outcome after corrective surgery. In this slide, I compare the heart rate variability of a twin with tetralogy of Fallot and severe heart failure due to aortopulmonary shunt and a healthy twin. The patient was treated with propranolol from the first days of life, and there's nearly similar development of heart rate variability in spectral analysis in these two twins. The heart rates of the patients are lower compared to the heart rate of the healthy twin. These are the growth and heart rates of the two twins with very low height SDS values in the patient and lower heart rates due to propranolol in the patient. We can clearly realize the beta blocker effect in the patient with lower heart rates compared to the healthy twin. Today, with nearly 10 years of life, there's a similar height and a similar heart rate and a similar heart rate variability in these twins. Looking to the whole group of patients, there's the same image with lower heart rates of propranolol treated patients with severe heart failure compared to healthy control. Also, the vagus activity measured as high-frequency power is only lower at the beginning of the therapy and increased to high normal values after introducing propranolol therapy in these infants with severe heart failure. These are the growth value of our entire Bad-Mergentheim group. There is very low SDS height at birth in this infants, most of all due to the genetic anomalies. At surgery, we have nearly normal height, and the height at 11 years of age is higher than normal. Compared to the published data with average heights in a great group of patients with congenital heart disease show lower heights at surgery and nearly normal heights at the age of 6 years. 8 of our infants suffer from Down syndrome and heart failure due to congenital heart disease. We know that growth in infants with Down syndrome correlate with the neurodevelopment. Our patients who are treated with propranolol show normal height SDS at surgery and over normal data in the later life, compared to 3 infants who are treated from other cardiologists who use ACE inhibitors and diuretics, and compared to the data from South Africa and Brazil, our infants with Down syndrome have a clearly better growth than those who are treated with standard therapy. In this slide, we compare our data with propranolol treatment to the data of the US enalapril trial. At baseline, we are similar lower height set scores in the whole group, with normalization of the SDS score at surgery after propranolol and further low values in the US enalapril trial at the age of 14 months. Um, the the enalapril treated patients have further low height Z scores, and our patients have a better growth. Looking to the head circumference data that correlate with neurodevelopment, we have the babies with the lowest head circumference Z score due to genetic anomalies. There is nearly the same data preoperative and late postoperative. There are significant lower values in enalapril-treated infants compared to placebo-treated infants, and the propranolol-treated infants have further uh, low SDS scores that are increasing over time. Looking to the data in the 12 years follow-up of our patient, we see the RMSSD parameter for vagus activity that increased after introduction of propranolol treatment, and we measure nearly normal values in further life. The same data are shown for the global heart rate variability SDNN. Again, there we show the low heart rate values after propranolol therapy in infancy and low normal values in later life. Today, the pediatric cardiologists are standing at a crossway in the treatment of heart failure in infants with congenital heart defects. The guidelines recommend a further neurohumoral escalation by using diuretic ACE inhibitors or catecholamines. We prefer the neurohumoral de-escalation by using beta blockers, as shown in the prospective randomized trials. Propranolol is the only drug who shows a decrease of the clinical heart failure score, a decrease of the neurohumoral activation, and an increase of heart rate variability. However, 4 infants died despite propranolol therapy, as shown in this slide. This is a baby with Down syndrome and a univentricular heart. She had a takedown after the gland operation and have to be changed to an aortic pulmonary shunt with very low heart rate variabilities postoperative. We introduced propranolol treatment and reached a slight increase of heart rate variability and decrease of heart rate. However, we didn't reach the value of a high power of 20 milliseconds, and the baby died without beta blocker therapy after a diagnostic catheter in the university hospital. This is a case report about the only infant who received beta blocker therapy who died in our hospital. Uh, we realized that the baby suffer not only by heart failure indicated by the very high NT-proBNP values, but also by systemic inflammation indicated by high uh, procalcitonin values, by high interleukin values, and high ferritin values. We have no possibility to improve this inflammatory disease with a beta blocker, and the baby died without beta blocker therapy at 6 months of life. How to treat infants with heart failure due to left to right shunts based on our experience with propranolol therapy. Today, I would not wait until the babies suffer from severe heart failure. I recommend starting propranolol therapy early in the case of hemodynamical significant shunt defects, which can also be done on an outpatient basis in stable infants. If the infants weigh 3 to 4 kilograms, it should be clinically monitored after the test dose of 1 milligram propranolol and then treated with 1 milligram propranolol 3 times a day. In Germany, we have a drug hemangiol developed for the treatment of infants with hemangioma. The dose can be increased by 1 milligram steps every 2 to 3 days up to the target dose of 2 milligram per kilogram body weight per day, or a heart rate approximately between 110 and 120 per minute. This treatment regimen has been shown to be safe in thousands of infants with hemangiomas and can be extended to infants with mild clinical signs of heart failure. How to improve the safety of propranolol treatment in infants with left to right shunt. Infants with ROS scores over 7 or 24-hour high frequency power below 20 milliseconds should be treated in hospitals with thorough monitoring by Holter ECGs. Infants with tachypnea should be recompensated using furosemide or hydrochlorothiazide with spironolactone. Those who have recurrent fever need diagnostic for inflammatory syndromes by using ferritin, procalcitonin, or normal blasts. Those with pulmonary overcirculation due to right ventricular outflow tract stenosis should receive additional digoxin. No ACE inhibitors in infants with severe heart failure due to the left to right shunts. You can document your therapy in such an observation sheet, and I would be happy to receive some sheets uh, for collect more data about beta blocker therapy in infants with heart failure due to congenital heart defects. Those who are interested in this new treatment of dysautonomia in children and adolescents can buy this book written in German. I hope to translate this book with the help of friends in the next months to show our data published in many publications and those of other authors who are interested in dysautonomia in children and adolescents. Thank you for your attention.